webinar and every different topic different times with an international and a national speaker. So today's theme is the limb lengthening, and we have excellent speakers today from Dr. Michael ASSAYAG from RUBIN Institute, Baltimore, USA. I welcome you, sir, to spare your time and given your consent to give your talk. And our own legend and our stalwart, Dr. MANGAL PARIHAR, he has spared his time to give, he will be talking on the limb lengthening, and Dr. SIDDHARTha, who will be doing the case discussion. So let's go ahead, and SIDDHARTha, I will hand over to SIDDHARTha and he will give a brief introduction and then we can start the talk. SIDDHARTha, please.
Well, thank you, Rajat sir. So clearly our esteemed faculty, they need no introduction. I don't think I can, supersede. But joining us from Mumbai is very, very senior and very experienced, the most experienced, I would say, limb lengthening orthopedic surgeon, Dr. Mangal Parihar, who is now joining us from Jaipur, in spite of his very busy schedule. And joining us live from Baltimore is Dr. Michael ASSAYAG, again, very, very experienced, from the SINAI Hospital of Baltimore, the International Center for Limb Lengthening. And as Dr. Rajat said, today's theme is limb lengthening, which attracts a lot of youngsters. There are a lot of controversies. So we have two very, very good talks. And to begin with, can I invite Dr. Mangal Parihar, sir, to share your screen, please?
Thank you. Meanwhile, I will like to welcome Dr. Dror Pele. Hello, sir. Welcome. And thank you for sparing your time to be in the panel. And we all are always inspired by you. And we welcome you, sir, to be in this panel, and you will be sharing us your experiences and the beautiful insights on the talk. I welcome you, sir, on behalf of the Asami India.
Thank you.
Welcome, Dr. Perry. Thank you for joining.
Hi, Dror. So first, I should start off. You know a little bit of Hindi, right? So I should start off by saying Namaste, Guruji. You know what Guruji is. So he's the guru who has taught everything that we know about Elizarov. He's the one who has inspired us. So, and I know he has very clear thought process in terms of cosmetic limb lengthening. So I'll start off with my talk, and then we can have comments and stuff from Dror. So the kind of way I've focused my talk is, should we be doing cosmetic lengthening? Or maybe that's not the right title. It should be probably who should be doing cosmetic lengthening. So there's no conflict between the first talk and the second talk. My talk is more to warn the younger, lesser experienced surgeons from falling into this trap of cosmetic lengthening till they are well experienced. And Michael is going to give tips and tricks to those of us who are more experienced. And he's going to sort of expose one of the facets of Elizarov for the younger surgeons. So in terms of indications, the only real indication, I think, is height dysmorphism. Now, this is a very vague and a gray term, but essentially it means people who are not, whose internal self-image of what their height should be and what their actual height does not match, and that causes quite a bit of emotional turbulence. The other commoner causes which people come asking for cosmetic lengthening is, I'm too short for the army, I want to get into films, I want to get into modeling, if I was taller I would be better. Marriage, people from the West want, they think that if they get taller, they will get more girlfriends and stuff like that. All of these, that second bunch, is complete BS. These are patients who will not really benefit from limb lengthening. Yes, somebody who's very experienced in very particular individuals may do it, but in general, I would say that is not something that the person who's starting out should get into at all. So these guys are, they have more reasonable height requirements. They don't come with demands of 10 centimeters and 16 centimeters. They 6 to 7 centimeters is something that can be safely done without too many complications. The moment you hit 6 and 7 centimeters, the number of complications starts increasing. They tend to be more motivated for working hard on all the rehab. They follow all the instructions that we give them. And this is the one group, I think, where attaining length is not a cosmetic thing, but it is a therapeutic thing for their emotional issues. Now, what does a cosmetic limb lengthening entail? Of course, all of us know that lengthening takes time for the regenerate, etc., to heal properly and solidify. And at a minimum, I would say it is 1.5 months per centimeter. The generally touted figure is 1 month per centimeter, but I don't think that's really true. It's even more than 1.5. It tends to be closer to 2 months per centimeter. So even if you say 1.5 months per centimeter, that's about 9 months for a 6 centimeter lengthening to heal. More than 6 or 7, you get many more complications. And all said and done, it takes them 10 to 12 months for attaining a normal gait. Now, one thing which many people don't realize, and unfortunately many surgeons don't explain to them, is that especially if they want to keep the lengthening hidden, which is most of them, they are away from friends and society while the frame is on. And if the family doesn't know of this, that's a surefire recipe for problems in India, at least. Maybe in the West, with people becoming independent earlier, it's a different issue. But in India, you remember the case in Hyderabad, where the parents didn't know where the son was. They complained to the police, and that led to a big problem for the surgeon himself. Now, unless they are working in something like IT, where they can continue working from home, getting to work also becomes a problem in a place like India, where public transport is not good. Transport for people who are challenged in any way is also not good. And the most important thing we have to think about is the concept that even though short, the person is completely normal in terms of range of motion, in terms of all the activities that he or she is able to do. And even if you give even if that patient gets 5 degrees less dorsiflexion at the end of that lengthening, he is going to become a tall abnormal, or I would say even a less short abnormal. And that is not a good deal in the long run. Which bone do we do lengthening? The tibia is easier, but the tibia has trouble in terms of the gastroc and the tight and the large muscle mass behind, which can lead to an equinus, a flexion deformity of the knee. The femur has more soft tissue, so healing may be better, but there are issues with the knee range of motion, a flexion deformity of the hip, and pin sides. LON, that is lengthening over nail in the tibia, I think is doable. Femur, personally, I would not do a femur lengthening over a nail. It's too troublesome a procedure for a cosmetic lengthening when there are other problems also. It entails, when you're doing a cosmetic lengthening, you can develop bony deformities if you are not careful about how you put your frame on, the stability of the femur, etc. In case of the femur and the tibia, but generally it is done in the femur. Now we have this precise nail, which used to be available in India. Since the last, I think, 5 or 6 months, it is not available because of some change in the company. And we don't know what, when that will be available again. You have to consider the cost of surgery and, importantly, the cost of physiotherapy. So this is a procedure which cannot be charged in the same way as you would charge for a tibial non-union or a tibial transport, for example. There's much more stuff involved in doing the surgery as well as post-operative care. Many of us may not have access. If you those of you who know about what happens in Baltimore in Florida with Dr. Paley's current center. There is a full physiotherapy department which works on these patients on a very regular basis, and not many of us have access to that kind of physiotherapy. So you have to ensure that the patient is going to have therapy. These patients themselves, for want of a better word, I would say, are demanding personalities. Many of them don't realize what all of this entails. They think it's just something as good as a nose job or a boob job. You get your surgery done, get it lengthened. So I would say about 80% of my patients, when I tell them all the negatives, they don't come back, which is a good thing. Some people who are pushing cosmetic lengthening as a factory procedure, they are given wrong time frames by doctors in their various fora that they discuss things in, and they are full of misinformation from the net in terms of they will know more about things like proportions, diets, alternative medicine, the use of pot than you have ever learned. And many a time their expectations tend to be unreasonable. Again, to underline, guys or people who are with this height dysmorphism kind of issue, many of them are motivated. They have very clear expectations, but I'm talking of the average Joe who comes for a cosmetic lengthening. Now, it involves also the surgeon. What is the surgeon's training? And as Dr. Paley always says, that cosmetic lengthening is the apex of reconstructive surgery. When you build your base with doing enough tibial non-unions and deformities, femur non-unions and deformities, unilateral post-traumatic lengthenings, then you are enabled, I would say, to do stuff like unilateral congenital lengthening, because these are the ones which give you the most trouble. And or cosmetic, you could move these two indications up or down. And in that situation, you can do a lengthening over nail of the tibia, or a lengthening over nail or lengthening and then nailing of the femur. Personally, I'm not much in favor of doing this for the femur. And for the average orthopedic surgeon, or even the person who's doing Elizarov, he would think that, oh, what's there to do in a nailing, especially when it comes to this precise, which is a implantable nail. I've done enough nailing. And there, I would say the difference is between a carpenter and a gardener. You getting that regenerate to heal and not having trouble with the regenerate is something that is learned over a long time, how to prevent and avoid problems. And you have all kinds of troubles from these lengthenings, just like Elizarov, but it tends to be a little amplified with these patients. And all of this leads to a loss of sleep for the surgeon. So we've done 10 patients with the precise nail, that is cosmetic limb lengthenings. We've done 6 with the precise for length discrepancies, one in the femur, 16 with LON on the tibia. And then I've treated 10 complications which have been done by other surgeons, some of whom Dr. Paley has made famous, I think. So then why am I advising you against doing a cosmetic lengthening? Do I want to, really try to corner the whole cosmetic limb lengthening market over here? No. I want you to avoid having trouble. So only after having a good experience with the Elizarov for regular usage, where you are able to apply the frame without too many complications, you are able to deal with the difficult outcomes or the poor outcomes of your own cases in terms of trauma. All of this allows you to avoid and recognize problems which are evolving in these difficult patients. You need to have a good physio as part of your team. And as I told you earlier, Dr. Paley and Baltimore, they have entire departments which are devoted to this. So the very least I think you need is a good physiotherapist. And you need the ability to identify the problem patients before surgery. Now, some of this is a seat of the pants flying. I don't think there's any real psychological test, etc., which can rule out trouble. So I usually try to find out what does the patient expect from the lengthening. I, for one, am absolutely, I demand that a family or a loved one should be a part of the consultation so that everyone hears what the complications, possible complications are. And I explain all of the negatives more than whatever are the positives, right? And therefore, if I have to do a cosmetic lengthening and the patient can afford it, the best is something like the precise nail, because that is the most convenient for the patient. The next best, I would say, is to do a lengthening over nail. I would only do that in the tibia. That gives us reduced fixator time, less chances of deformity due to an unstable fixator. But because you're putting the nail in and you may not be able to put in all the wires and pins that you would normally, stability can be an issue. At the end of the lengthening, because you put the nail only till where you are allowed by the distal ring. And then as you distract, the nail retracts in the distal fragment. So essentially, at the end of the lengthening, you get a smaller length of nail in the distal fragment. And we tend to use a thinner nail compared to trauma nails in lengthening over a nail, so that we don't have any jamming of the nail. Lengthening and then nailing, the stability issues are improved, but I think there are other troubles in terms of maintaining the length, the sterility and things like that. So this, one could argue between LON and LATN. So I will leave you with a couple of patients, one with someone else has done, one which I have done, where there have been significant problems. So there was this 16-year-old girl who was brought by the father, who came to inquire about stature lengthening. And during the consultation, the sense I got is that the child is less, should I say, wanting the lengthening compared to the father. So they'd come from somewhere in the Middle East, and she was otherwise normal. And dad had come with the idea that, okay, now we've come from such and such place, and we've come ready for the lengthening, and I want you to do the lengthening tomorrow. I remember this very clearly. This was one of the last consults on a busy day in the evening, and then I spent another 45 minutes to an hour with him, trying to couch it in polite terms that she's at a age where she's not fully mature enough, because girls, I think, by this age are capable, and I got the sense that she's being pushed for the surgery. So I said, let her finish her studies now. Then once the exams are over, both of you all come over, and we shall arrange for counseling and then take it forward. And what I really meant by that was counseling both for the child as well as mom and dad, to find out where these problems are and try and explain to them that this is not necessarily the right case. Now, when they were with me, they said yes, 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 and then they went to another eminent surgeon who probably thought that, oh, it's I can do a nail, and he did all of this. They had some splints. She's been following up. So this was July 2019, and she came to me in October 20. She had significant deformities. She had been given Botox followed by a cast and stuff. So she had a flexion deformity in both knees of about 20 degrees, equinus of about 30 degrees, no further passive stretching. She had very poor quadriceps. That means she had not been doing her exercises well. She was walking with a crouched gait. Scars were all fine. And she had a lengthening with the precise in the tibia. An attempt had been made to stretch it out forcibly. So they caused heterotopic ossification in the knee. They avulsed the insertion of the tuberosity of the calcaneum. And the regenerate was healing, but she was walking terribly, significant dystrophic appearance. So I said, right now you stop all this passive therapy. She has to undergo aggressive, active range of motion, and then we'll see what to do for the knee and the ankle. So at 2 years post-surgery, after she'd been doing and her muscle strength and all has improved, this was her position where she had a manipulation under anesthesia to see whether not really a manipulation, a plaster under anesthesia to see whether anesthesia relaxes any spasm, etc. Her equinus and flexion deformity persists. She is ambulant, but she's dependent, and that is her X-ray. So the bone is healed, but this whole issue of the knee contracture, the ankle equinus, etc., still needs to be solved. So she's at the moment, suffering all the troubles that she has because of a lengthening, which probably, according to me, should not have been done. So here, you have to learn to say no to patients. Lengthening, as we already know, actually, is not only of the bone. Patient should have very regular therapy and stop when lengthening is not keeping up. I mean, the therapy is not keeping up with the lengthening, then you stop the lengthening. And this is something I warn patients about, that if I find that you are developing contractures which is not resolving with therapy, the lengthening stops there, following the same principle that a short normal is better than a long abnormal, right? So I think this is a case to underline all the troubles that can happen, because this was done by a surgeon who is not someone who is starting off. This was done by a surgeon who was well experienced with other kinds of surgeries, but not necessarily with limb lengthening. So with that, I will end here and open up for questions. Thank you.
Thank you, sir.
Dr. Mangal, sir. Yes.
Yeah. Thank you, sir. Thank you, sir, for the excellent insight about the real world of the cosmetic limb lengthening. And before asking the questions, I will invite Dr. Pelly to tell his experiences and his recommendations on cosmetic lengthening. Sir, what's your recommendation?
Thank you. Thank you for inviting me, and it's a pleasure always to come back and speak to Indian orthopedic surgeons. It's a very important subject right now. I've been doing cosmetic lengthening for 36 years. My first case was of cosmetic was 1988. My first case for achondroplasia was 1987. So for stature lengthening, whether it's for dysplasias or for cosmetic, I've been doing it a long time, and I've done hundreds, if not already thousands of cases in that time. We currently do more than 100 cases of cosmetic lengthenings a year, and that number has obviously grown. But I've learned a lot in this field, and I'd like to share with you some of those lessons. The first 22 years I did this, and I was in Baltimore at that time. I used to be the director at the RUBIN Institute, and I moved from there to Florida 14 years ago. But during that time, I worked, I was the only surgeon almost in the United States doing cosmetic lengthening. And I worked with a psychologist. We had every single patient evaluated. And we learned that basically the motivation for the majority of people who want to do this is they're driven by being bothered by their height. They're unhappy with their height. We therefore gave this condition a name, height dysphoria. I don't think you should use the name that you used, height dysmorphism, because in fact, this is not a dysmorphism. They're normally morphic. They're normally these are people without disproportion, without any dysmorphism, as opposed to our dysplastic group, which truly have dysmorphism. So these people are psychologically bothered by their height. It starts in adolescence usually. They feel juvenilization because they're treated younger than they really are due to their height. They're bothered by it for a long time. There are many, many causes. There's many books written about this, articles written about this, huge amount of literature about the effect of height on economics, on jobs, on partnering, and so on and so on. I won't get into that. But what we studied when we looked at this, we found that every one of these had a similar personality type, that they were really bothered by their height. And you could give them psychologic therapy as much as you wanted. It didn't change anything. They continued to be bothered by their height. The only thing that changed anything is actually doing surgery in an attempt to increase their height. And what we found is that the amount we lengthened was not related to the satisfaction or to the result. The amount we lengthened, in fact, several patients stopped short of their goal. What it did is it turned off a switch. There's like some switch that's on that as long as they can't do anything about their height, it's on. The moment you do something, you turn that switch off. And these people who are truly miserable because of their height, suddenly they're happy. I could tell you numerous stories about patients who underwent this, and it totally changed their confidence, their outlook on life, many, many things, because they had this surgery done. Now, part of it is predicated on achieving the goals of the lengthening. And the problem is that lengthening, you don't always achieve your goals, and you create a lot of complications, as Mangal mentioned, and there are risks of that. And so there's a few things that we have to consider as orthopedic surgeons. And by the way, in my early days, I used to have a psychologist evaluate them. I don't do that anymore. I'm able to evaluate them myself, but I'm also convinced now that we're doing the right thing for most of these patients. Now, I've treated hundreds of them, okay? It's different than somebody doing their first one. They've gone to a limb lengthening course and they know how to put an external fixator or a nail inside and lengthen. As was pointed out, that is fraught with complications and disasters. And really, we need to avoid that. For the first 22 years of doing this, I was a salaried physician. And even though these patients are paying cash, this is not covered by insurance, I'd never profited from 22 years of treating these patients. I am now in private practice, and I do profit from treating patients who are cosmetic because I'm in private practice. But it was never my motivation. Why am I mentioning this? Because it is the motivation for 99% of surgeons who are doing this. The reason surgeons want to do cosmetic lengthening is mercenary. I'm being completely honest. There is no other reason that any surgeon wants to do cosmetic limb lengthening. They're doing it for money. I did it originally not for money for 22 years because I felt that somebody needed to figure out how to do it safely, reliably, and reproducibly. I am in private practice, so I do profit now from doing this type of surgery. The problem is that when it becomes profitable to people to do this, and especially in the United States, I can tell you our reimbursement is being limited by government, by various insurance companies, and so on. There is this strong motivation to do it for money. And that tampers with judgment. And therefore, these patients become preyed upon by doctors from all over the world because this is a cash business. And so this has become a real problem worldwide. I can tell you that in India, you have one center, I won't mention the doctor's name so I don't get sued, but you have one center in New Delhi by a surgeon there who you need to stop because he is hurting people. I see so many of his complications, and he is simply doing this for profit with no care or consideration for patients, and he's hurting patients. We had a surgeon like that in the United States. His name was George Vito. I do mention his name because he has been sued, and he has actually lost his license to practice. And he was doing terrible things in the 1990s and early 2000s to patients, and causing one complication after another: malunions, non-unions, peroneal nerve palsies, contractures, arthritis, and so on. One of the patients he treated committed suicide because he was so upset by his final result. I operated on 8 of his patients to fix the problems. The surgeon in India, I've now operated on about 7 or 8 of his patients. I will not mention his name. But the point is that this has to be done responsibly. Yes, it is lucrative. Yes, surgeons make money because it is cash pay. And this is a huge problem. So cosmetic lengthening, there is like any other cosmetic surgery in that it is a body image disorder. That's what's wrong with these patients. They have a body image. They're not doing it to be a better basketball player, and they're usually not doing it to be, to be a model or this or that. They're doing it because they have a body image outlook that is distorted, and this fixes that. It really does. We've proven that in psychologic testing. We've published that. But we can really cripple these people and not return them to previous level of function. We've looked at our patients, and we get our patients back to previous level of function. That's a very tall order. Remember, these patients are starting 100% functional. You can't make them more functional. Orthopedic surgeons are used to treating pain and disability. That's what we're experts at. We've never been trained to be cosmetic surgeons. Now, everybody wants a piece of that lucrative cosmetic market, which is what's driving surgeons to do this. There's not a single surgeon out there anymore who's doing this because they really want to improve patients' body image disorder. They want to improve it for money, and that's the only reason. And it's okay to do that. Plastic surgeons do this all the time. They improve other people's body image problems for money, but they do it responsibly, hopefully. We need to do it responsibly. And to do so, just knowing how to put a nail in or a fixator on is not enough. You have to have the infrastructure to support this. We have irresponsible surgeons in the United States right now who see the patient, put the nails in, give them instructions, send them home, tell them they should do stem therapy, and there's no follow-up. And it's complete, and these patients are getting into lots of trouble. So I fix problems from almost every cosmetic limb lengthening surgeon in the United States. Not all, but a lot of them, because the majority are not experienced surgeons. I don't fix Dr. Assayag's problems. He's doing a good job. Okay. But my point is, and I'm sure Michael sees patients like this too, who come from other centers and they're not given a therapy program. They're told to go lengthen. They're barely given x-rays on a routine basis. But sure, they collect the fees from these patients. So this has to be done responsibly. I have published a paper on this, of how to do this, how to do it correctly, and all the various steps. And I think unless you can provide that support to the patient, including rehab, including every 2-week follow-up, including a knowledge of how to treat complications. You should never do a surgery that you don't know how to manage the complications. So here's a question that anybody who wants to do cosmetic limb lengthening needs to ask themselves. Do you know how to treat the complications of limb lengthening? Do you know how to treat knee contractures? Do you know how to treat ankle contractures? Do you know how to treat poor regenerate? Do you know how to treat premature consolidation? Do you know how to treat nerve entrapment that occurs during lengthening, like a drop foot, peroneal nerve palsy, that kind of thing? Do you not? So let me put it in terms that every orthopedic surgeon understands. If you do joint replacement of the hip, let's take the most common, ubiquitous, procedure done. Is there any joint replacement surgeon who does joint replacement surgery without knowing how to treat a dislocated hip replacement? Of course not. Is there anyone who does knee arthroscopy that doesn't know how to treat septic arthritis of the knee after knee arthroscopy? Of course not. And so on and so on. So the majority of people who do cosmetic limb lengthening have no idea how to treat the stiff knee that occurs, the equinus ankle that occurs, the poor regenerate that occurs, the chronic pain that occurs, the nerve entrapment that occurs. You know what that means? They should not be allowed to do limb lengthening. You got to know all of that. And the true sign that someone is prepared, adequately prepared to do cosmetic limb lengthening, is that they have cut their teeth on limb lengthening for limb length discrepancy. They have experience treating either congenital, developmental, or post-traumatic limb length discrepancy with the same implants that they're planning to do for cosmetic. So the discussion today should not be on what's the best device to use for cosmetic limb lengthening. Is it the fixator? Is it this? Is it that? Well, we have cost considerations. We can't afford an implantable nail. They don't sell it in India. We can get into all that. The discussion is so much more basic. Is who should be doing this? Mangal hit the nail on the head. So to start with, it should only be experts in limb lengthening, not experts in collecting money from patients who can afford to pay. I think everyone's an expert in that. Okay. So this is a very serious thing. We are crippling people. I'm not. I'm sure Michael's not. I'm sure Mangal's not. Okay. But as an example, you have a surgeon that you should discipline, and somehow he should lose his license to practice in New Delhi. And, I'm happy to provide that name privately, but not on a public forum like this. But that surgeon is out of control, and he makes all of your country surgeons look bad. And there's only one reason he's doing this: money. There's a group in Turkey does the same thing. I see one patient after another of theirs with complications. I see them from all kinds of centers, whether they're American or around the world. They're all undercutting each other on cost, because that is a limiting factor for most patients, is that this costs a lot. Let's take in the United States. The cost of this in the United States, okay, from different surgeons, if you include all medical costs, ranges from $80,000 to $100,000. Okay. The implants themselves, we're all using the precise nails. So the implants themselves are at least $15,000 a nail. So, I mean, at $30,000 of that is just implant costs. I know that's really unaffordable for most Indians. Okay. But in that is a good chunk for the surgeon and a good chunk for the hospitals. There's a lot of motivation to do this. But the cost of this is chronic pain, disability, and reduced function. And so we really have to think about who should be doing this. How do you regulate this? There is no way in the United States to do this right now. Okay. You guys should think about this for India. And if your group is responsible, then they'll come up with guidelines for that. In the United States, this has been controversial for a very long time. It's become less and less controversial and has become accepted. And you see articles in the newspaper and on TV all the time about this. But it's driven by economics. It's driven by patient demand and by economics. It has become easier with the implantable nails, probably fewer complications, but the principles are the same. The ethics and morals of this are the same. The responsibility remains the same. So I'll kind of end that. I'm happy to come back to that. I haven't talked about what's the best way of doing this. What do you need to know? You know, things like, do you do iliotibial band release proximally or distally? Do you do that in every femoral lengthening? Is there a role for tendo-Achilles lengthening or gastrosoleus recession, or should you avoid that completely? What about fixators, lengthening over nail versus nails if we can't afford the implantable nails? These are all good questions, but I don't think time allows me to kind of expound at all those areas. Thank you.
Thank you, sir. For all these queries which we will be having, we will be needing your lecture in the coming months, a detailed lecture on the management of the complications. And so thank you, sir, for the real insight, what's going on around the world. And now I invite Dr. Michael for his talk on the limb lengthening. Dr. Michael, please.
All right, thank you so much for the invitation, and it's an honor to participate to this panel and to be talking after Dr. Paley, who, just like Dr. Parihar, really hit the nail on the head. And I'm lucky enough to be working in a center that was pioneered, obviously, by Dr. Paley himself and Dr. Herzenberg. I got to learn from their wisdom. Actually, as a disclaimer, I am now the salaried surgeon who does it because I was tired of seeing the complications from these centers who do not seem to learn from their complications, because patient after patient comes in with the same complication, and oftentimes complications that are extremely preventable with just a little bit of knowledge and a little bit of insight. So without further ado, staying out of trouble in height enhancement surgery, stature lengthening surgery, call it what you will, it's cosmetic height surgery. Full disclosures, I am not being paid for anything. And this is me in Pune in 2019, wearing the Pune hat, the teaching Pune hat, and me with Dr. Shamsul. Thank you so much for the invitation. There used to be a time where limb lengthening was only something of cosmetic limb lengthening of science fiction. And historically, it was done with cumbersome external fixators. And, sometimes it still is with various methods. However, as the technology improved and with the coming of internal lengthening devices, comfort has greatly improved. And it has really increased the desire, it has increased the market into this field. Basically, more and more people realize that it's accessible, it is not scary anymore, and they want to pursue the quest for being taller. Why do they do that? Well, Dr. Paley coined the term, he talked about it earlier, of height dysphoria or height neurosis. And basically, it's a perception, a distorted perception of self-body image that creates a lot of anxiety for multiple reasons, both personal and social, due to unhappiness about their height. What's extremely interesting is that it is irrespective of the height. We see people who are 150 centimeters that have height dysphoria, but we also see people who are 182 centimeters with height dysphoria. And it really comes from that self-body image that is distorted. But there's a very vast body of research about it. We know, quote unquote, that tall people are more successful. Even in academia, we know that chairmen in the US are on average 2.14 inches taller than professors, who in turn are taller than associate professors and assistant professors, right? And the assistant professors themselves are 1.25 inches taller than the average population of their age. There's a vast body of literature also on the topic. Malcolm Gladwell, in his book Blink, studied a population of CEOs. And basically, he saw that about 15% of the population are 6 feet or over. In metric, it's 185 centimeters. However, amongst the Fortune 500 companies, that number is close to 60%, which is completely disproportional to the rest of the population. 3.9% of adult male are 6'2" or taller, but is in his sample of CEO, it was 30%. There is a concept of height premium. Tall people make more money. And some studies have showed that height is positively associated with an increase in income, but quote unquote, an increase in cognitive abilities. This is a very common complaint. Short people cannot get dates, right? It's extremely difficult for short men to find a suitable mate. And that has seen spawning a lot of online communities, the limb lengthening forums, YouTube channels, Discord channels of men and some women who gather and complain about their height and try to find solutions. They advise each other. However, these communities are also a nest of misinformation and some good information hidden in between. So in 2020, my old mentor, Dr. Robert Rosbrook, and myself have published in JLLR about the psychological and orthopedic outcome of stature lengthening surgery using IM nails. And what we found is that it is safe, right? 100% of patients regain excellent Asami pain and functional scores. And with an average of 6.4 centimeters of new height, there were clinically and statistically significant improvement in self-body image in everyday activities. And that was done using validated scores from the body image literature. And we know from multiple studies and meta-analyses and systematic reviews, pardon me, that cosmetic stature lengthening is safe and has a low rate of severe complications when done in the right hands. And we're going to talk about that in a second. But really, we live in a world of cosmetic procedures. It's become completely accepted in most fields of surgery. Plastic surgeons do it all the time. OMFS, ENTs, oculoplastics, dermatologists, practitioners. Social media is full of people showing off their breast augmentations, their butt lifts, their new shin, their injectables. And it's time we start talking about cosmetic orthopedic surgery. Historically, orthopedic surgeons, and still now, are shunning cosmetic procedures. We are functional surgeons. We want to address problems, and we would never dare operate on someone who has no functional issue. But the truth of the matter is, the population demands it. There is a demand, growing demand for height lengthening surgery, but there's also a growing demand for knock-knee corrections, bow leg corrections, rotational corrections, which creates a lot of mental anguish for some patients, for some people. So who gets cosmetic lengthening? Well, it's a majority of male, some females. They're highly organized. They've done their research extensively. Most of them have met all the surgeons and know the pedigree of all the surgeons on the market. They're high demand, they're high anxiety. It's not dissociable from their problem, which is height dysphoria. And I spent on average 3 to 4 hours with each patient in active discussion before they schedule, and a couple more hours before they get to the operating room. So they're extremely high demand. And I'll go as far as saying that there's easier ways to make money. My joint replacement partners make a lot more money than I do doing cosmetic height lengthening and limb lengthening surgery. Minu Patel has published an editorial in JLLR in 2017 saying, you know, cosmetic limb lengthening is the elephant in the room, and it's going nowhere, right? It's here to stay. So rather than prohibit it and rather than taking a hard stance against it, well, we should mitigate the harm. We should decrease the harm done to these patients who go to, you know, the lowest bidder and provides with subpar standards, subpar surgery, and end up with crippling complications. And he came up with these guidelines to which I abide, I believe, fully. This surgery should be done by experienced fellowship-trained limb lengthening surgeons. It should be done in major hospitals with backup facilities. One should have access to ICU. One should be able to either start or have access to ECMO. There should be no coercion. There should be no non-refundable financial deposit done. And as Dr. Pili mentioned, there should be national bodies that have the duty to report and reprimand underperforming and exploitative colleagues and those that indulge in unethical practice. So with that being said, how do we stay out of trouble in height lengthening surgery? Well, I break it down in at least 3 phases, right? The preoperative phase, the intraoperative phase, and the postoperative phase. And I'll go back to that slide because it's so important. Preoperatively, you want to abide by ethical conduct, right? First, do no harm. And the only way to do no harm in doing cosmetic height surgery is to know what one is doing. Cosmetic height surgery and limb lengthening in general is a world of obstacles. It's a world of problem. It's a world of complications. And the only way to avoid all those problems and complications is to know about them, to know how to prevent them. And really, experience and training is key. Second thing is there should be some form of psychological evaluation, whether it's done by a trained psychologist or therapist or by the surgeon themselves with enough experience in the field to recognize problematic behaviors. So where my opinion differs than Dr. Pili's is that we do have a bias as surgeons because the people who end up in our office to undergo this procedure have failed everything else. They have failed the conservative treatment. I routinely meet highly successful people. Not so long ago, I met the CMO, Chief Medical Officer of a hospital nearby. Not too tall, 5'6" or so, highly successful. And he told me, you know what, I used to consider that, but then, you know, I have a beautiful wife. I'm Chief Medical Officer. I'm 38 years old. I have enough money, and I don't think about my height anymore. The guy is jacked, hits the gym nonstop, because he found other ways to get that self-body image. Well, us as surgeons, we don't see these patients because they usually don't end up in our office. But for some people, it may be beneficial. I think it's important as well to recognize the true body dysmorphic disorders. So the people who, no matter how tall they're going to be, no matter how beautiful they're going to be, are still going to be unhappy about their appearance. The obsessive compulsive disorders who will buck on X-ray details, millimeters, half degrees, those who won't understand the difference between X-ray findings and clinical significance. And then severe mood disorders and self-harm ideations as well should be avoided. So this is the example of a 27-year-old male came into my office with a respectable height of 176 centimeters, which is 5'10". He's always had the dream of being at least 6 foot tall. He stated that his reasons were because he was always surrounded by taller people, and despite the fact that he was already tall, his whole family was taller than him, and also wanted to be a fashion model. He was a fashion model, but wanted to reach higher end brands that told him that he was too short. So it was very convincing. I booked him for surgery, and 4 months later, he reached a whole 8 centimeters and was extremely happy. You can see his post lengthening height at 185 centimeters, extremely happy. Until a week later, where he calls and he really would like to shorten 3 millimeters because he doesn't like his proportions, and 7 is his lucky number, so he'd like to reach 77. And a week later, he wants to shorten another full centimeters. And he comes back 3 weeks later, and he shortened down to 5 centimeters. And at that point, he can't stand without falling. His quadriceps are overstretched. He became super weak, and he was provided with braces and told to stop shortening. Comes back a week later, and he shortened down to 3 centimeters. We take his ERC back, and then I get a phone call from NuVasive telling me that the patient is reaching out and he's asking for an ERC. By that time, he's wheelchair bound. He cannot ambulate. He cannot extend, despite many hours of counseling and discussion and a recommendation to see a psychiatrist. He disappears, and I've never heard from him again. That was a couple of years back. So that's an example on how identifying a patient where, or lack thereof, missing a patient that has much deeper psychological problem than just a body height issue can really cause problems. Number 2, set realistic expectations. A patient who walks into your office and asks for 25 centimeters of height is not reasonable, okay? And this is a situation where you want to set the record straight. A realistic expectation is 5 to 8 centimeters in a single lengthening, 10 to 12, maybe in 2 processes, in 2 lengthenings, maybe up to 13. But more than that will start having an impact on function. Earlier, I heard Dr. PARIHAR say we have to know when to stop. Well, as limb lengthening surgeons, we have to make it clear to patients that we don't guarantee lengthening results. We don't guarantee a height. We guarantee a function. And the reason why they come to us is because we do not sacrifice function for numbers or speed, for that matter. So this is the example of a 49-year-old male, 47 when he started, who was 5'7", wanted to do the femoral lengthening, had a realistic expectation of 7 centimeters, and reached his goal beautifully. This gentleman has a YouTube channel where he describes this process. Came back a year and a half later with external tibial torsion and says, well, if you correct my external tibial torsion, can you lengthen my tibias as well? And this is him after a couple more inches in the tibias, an inch and a half. Those are his x-rays. Beautiful regenerate throughout the lengthening, beautiful regenerate towards the end. So this is an example on how having a successful, my apologies, having a realistic expectation, a realistic goal can lead to a successful procedure. This is a young woman who was 4'9", was always felt like she was being treated like a child because she had effectively the height of a child. She walked into my office scared. She walked into my office with a lack of confidence. And now when I see her, she bloomed into this beautiful young woman, confident. You know, she laughs, whereas before she never laughed, or I never saw her laugh. Now she laughs, she's happy. A year and a half later, after an 8 centimeter lengthening, she ran 10 kilometers. She ran a race and has normal function. I'm showing this video. It was taken 6 months after surgery, and by no means do I want to make anyone believe that this is the norm, okay? 6 months after surgery, a lot of patients are still using crutches. They're still using a walker with the current technique of internal limb lengthening device. However, I'm showing this with her consent. This is how she walks after 6 months with a bone that is healed enough to allow this amount of weight bearing. A little unsteady on her feet still, but she's doing well. This is what we should expect as a function, if not at 6 months, more around the lines of 9 to 10 months. Another gentleman who comes in with a goal of 5 to 6 inches over the course of 2 to 3 surgeries. And he comes in, he's done his research, he knows that it's not possible over the course of 1 surgery. He says, I have 3 years, COVID just hit. I know that I can work remotely and I want to do this. Goes from 5'1" to 5'4", or at least 5'2" to 5'4" after a tibia lengthening, and then reaches 5'7" with another lengthening. Now he's 5'7", his bones are fully healed, extremely happy with his function. However, despite that, you can notice the gentleman on the left, he's still hunching. And when asked, why do you hunch? He said, well, I don't want people to notice too much my new height. You're looking at people who their whole life, they wanted to be taller. And yet they still feel stigmatized by the fact that society doesn't yet accept limb lengthening as a procedure. He's clearly, when he doesn't hunch, he's clearly the tallest person on this picture. But still, he has this fear of being unmasked. Extremely happy with his height. This is him 2 years after this quadrilateral lengthening. I'm showing this with his consent. Beautiful gait, walks completely normally, and can run without a problem. This was the day before his hardware removal. And I could show examples over examples over examples on how realistic expectations yields good result. This is another young woman suffering from Turner syndrome. So not purely statural lengthening. She went from 4'6" to 5'2", I believe. Extremely happy with the result. Also, you have to let patients know in advance, we're still preoperatively here, that there's a world of potential complications. I often hear patients come into my office and say, I've met surgeons who made it seem like it would be easy to gain 15 centimeters of height with a quadrilateral lengthening, both femurs, both tibia at the same time. Well, the truth is it's not. It's hard work. It's the toughest procedure. It's the toughest thing that they'll most likely ever do physically. And they have to know that the potential complications of this procedure are life-threatening, function-threatening, and limb-threatening as well, if not handled properly. Now, during surgery, how do we stay out of trouble? Well, first, know the technique you're about to use, whether the technique is lengthening over a nail, circular fixator, circular hexapod, or all the different types of internal lengthening device. And for each method, careful, meticulous planning is key. You got to know the pros from each technique. You got to know which adjunct procedures to add and how to modulate your surgery according to the technique that you're using. This is the example of a young patient in his 20s who went to a very prominent practice in the United States, obviously not Paley Center, but a practice that advertises very heavily. And then 3 surgeries later with wrong entry points and attempts at fixing it and improperly placed blocking screws, this is the result. The patient is devastated, right? He's looking for a solution. The first thing they ask is, he asked was, am I ever going to be normal again? This is a 30-year-old male who weighs 80 kilos, who went to, once again, another extremely quote unquote reputable practice outside of the United States. And if you look carefully at that image, The nail that was used here is an 8.5 millimeter, which for all intensive purposes is a pediatric nail. It's a nail that is contraindicated above 57 kilos of body weight. It's extremely unstable. And what had to happen happened. After 3 centimeters of height, both nails failed in bending. This is a catastrophe. Another example of improper nail sizing, improper entry point, improper position of a syndesmotic screw and its effect on the ankle. Well, believe it or not, this patient has seen the money signs at the end of this procedure, and despite these horrific iatrogenic complications that could have been easily avoided with a little bit of skills and technique, has opened his own limb lengthening center with the surgeons that did this, and is advertising heavily the services. Number 2, perform the adjunct procedures that are necessary. And this is a whole topic on its own. Not everyone agrees with which adjunct procedures need to be done or when they need to be done. But as a rule of thumb, some form of IT band fasciotomy has to be done for femoral lengthening, proper entry point as well. Tibial lengthening has to see syndesmotic fixation. We could discuss and debate for a long time about the need for gastrocnemius recession and should they be done preoperatively or postoperatively when equinus contracture and positive silver skull test appears. Nevertheless, it is a very useful adjunct procedure in this treatment. Common peroneal neurolysis, especially if there's been a previous lengthening above. Do we do it preoperatively or postoperatively? Down there is the image of a patient who went to a practice in Germany that, quote unquote, does not believe in IT band tenotomies. And after 5 centimeters of height, he's walking on the left, cannot fully extend his knees, cannot bring his legs together. And only after a complete IT band release and a lot of physical therapy was he able to overcome these bad contractures. This is the example of another patient who went to that same practice in Germany, where the osteotomy was performed with a saw rather than low velocity osteotomy technique. And what you can see is that there is sclerosis at the edges of the bone, there's bone resorption at the edges, and there's a big cystic formation. There is no regenerate in there. So perform a low velocity osteotomy anytime you're doing distraction osteogenesis. My method of choice is the Di Bastiani technique, multiple drill hole and osteotome. Beware fat embolism. Fat embolism is the killer. Know how to recognize him and be in constant discussion with the anesthesiologist about the appearance of drop in blood pressure, a drop in oxygen saturation, and an increase in peak inspiratory pressure. And the ways to avoid it is by being extremely deliberate and careful in drilling vent holes, in doing a low-speed reaming, and using the best nail size for this patient. But when push comes to shove, having ICU in your facility and the capacity to start or perform ECMO is the way to go. When using LON, or for any reason when bringing back a patient into the operating room, especially after lengthening, avoid forceful hip flexion and knee extension. I get patients routinely who come from some international practices, and after the second stage, they had sciatic nerve palsy. And I attribute it to the fact that assistants just forcefully bend the hip and extend the knee when doing the prep on a patient who is not awake or aware to mention that it hurts, and they end up with traction injuries to the sciatic nerve. And when performing EMG, the EMGs support that hypothesis. And finally, anyone can apply an external fixator or insert a nail, but that's really what the problem is. What makes the difference between a successful limb lengthening and a failed crippling limb lengthening is the decision-making. It's the postoperative period. It's everything that goes afterwards. Identify and treat compartment syndrome, right? Promptly. Maybe even avoid nerve blocks in patients who are undergoing tibial lengthening. And if doing a nerve block, an indwelling catheter that can be titrated is a better idea than a complete block that leads to catastrophic complications. Don't lengthen too fast. Slow and steady wins the race. I've rarely, if ever, seen premature consolidation in a grown adult. I think premature consolidation is the thing of pediatrics, where slow and steady creates better regenerate, allows for the soft tissues to adapt, and allow for the physical therapist to catch up joint contractures. And that being said, proper experienced physical therapy is key. Physical therapy can kill or make a lengthening. Patients who go back to their home state are making a big mistake because they don't have the support system from an experienced limb lengthening center to achieve their goal. So this is the example of someone who did a quadrilateral lengthening at an unchecked speed. Some practices lengthen even at a ridiculous rate of 2 millimeters per day. And this is the end result. Severe hip flexion contractures, knee flexion deformities, knee flexion contractures, ankle equinus contractures, toe walking. This is a catastrophe. This will not yield a functional result. This patient wrote on the forums, hey guys, anybody else develop drop foot with tibial ON? Well, flash news, it is not normal to develop foot drop. And it should be addressed promptly. And when that patient reached out and I asked, well, did you get a common peroneal nerve neurolysis? Did your surgeon address the length, the speed of lengthening? Did he shorten maybe your lengthening? The answer was no, no, and no. An example of a patient who lengthened too fast as well, and in which the bone regenerator was not addressed promptly enough, and the speed of lengthening was not addressed promptly enough, and ended up with atrophic bone edges and essentially a 5 centimeter bone defect. This is what he looks like after bone grafting and as a later night infusion. And for that reason, to avoid problems, these patients need to stay local. They need to have direct access to their limb lengthening center and have bi-weekly follow-ups. They need new x-rays every 2 weeks. They need a careful physical examination, know what to look for, okay? But also, burnout is real. Limb lengthening burnout is something that exists. These patients, after a few weeks to a few months, have had enough. They need you to check on their psychological well-being, and that's why having a good social support, having people with them, having family that helps them, can really be a great adjunct to their lengthening. And finally, address complications promptly. And ideally, you wouldn't want to have to address them after the fact. You want to be able to prevent them during those biweekly visits by modulating the speed of lengthening. And most of the complications I talked about earlier can be addressed that simple way, by just slowing down, taking a break, shortening temporarily and lengthening again, increasing your patient's nutritional intake, optimizing it, increasing their supplementation. There's multiple ways to skin a cat, okay? Another example of a patient who ended up with crippling deformities and who had to be treated by my partner, Dr. Conway, to correct the deformities and the bone defects. And finally, curb the over-enthusiastic and overzealous patient who thinks, well, it doesn't hurt, let me walk unchecked. Okay, each method and each implant has a different weight-bearing capacity. A circular external fixator, a hexapod, has more lengthening capacity than the current precise nail, but still curb them because implant failures do occur. Okay, so buyers beware. The patient should be aware of all the potential complications, and I put this slide again because it's so important. This is not a walk in the park. This is potentially a crippling procedure if not done properly. And let's all remember the rules of ethical cosmetic limb lengthening. and the most important are that should be done in experienced hands with experienced facilities, and there should be some form of governing body that identifies problematic providers, surgeons, and disciplines them. It doesn't have to be, revoking a license. It can be forcing these surgeons to have proper training of the proper length, not just a weekend course, and review their cases and learn from their mistakes. So in conclusion, cosmetic orthopedics is here to stay, whether it's height lengthening, knock-knee correction, bow leg correction, whether we like it or not. So we have to start creating clear guidelines on how to perform them safely, just like other surgical specialties have done. And despite the fact that internal lengthening devices are sexy and are easy to use in surgery, distraction osteogenesis is still distraction osteogenesis, and it has to be treated with humility properly. And finally, know all the potential pitfalls at every step, and prevention is key. Thank you so much, Dr. Hoda, for this invitation. And for those who have never come, have never been, put these dates in your calendar. August 21st to 25th, 2024 will be the 34th Baltimore Limb Deformity course, and we look forward to seeing everyone in big numbers. On that, I would like to open the stage to the panel.
Okay. Thank you, Doctor. Thank you, Michael, for the detailed, extensive presentation on all the aspects, the pre-op, the intra-op, and the post-op. Okay. I have one question, like just a curiosity. Like in US, roughly how many percentage of the surgeons are doing precise nail compared to lengthening over nail or the hexapod? Are majority, what I have a feeling like majority are with the precise nail. What's the current percentage?
I think currently pretty much all the surgeons on the market offer internal lengthenings with precise. And there's a few reasons, but there's an ensemble of complications and problems with external fixation lengthenings and lengthening over nails that are simply not acceptable for cosmetic purposes, right? In terms of function. Remember, we take someone who's completely functional and we want to make them the same but taller. That's one reason. Reason number two is that the cost of healthcare in the United States doesn't necessarily make lengthening over a nail or external fixation lengthening that much cheaper. And the regulations that mandate to use brand new implants every time and return to the operating room to remove the hardware and to lock the nails. So there's not a big cost benefit, and there's risks for function that are not acceptable for American surgeons. I don't know if Dr. Pillay wants to add to that.
Sure. No, I think you're right. LON is not necessarily cheaper in the US because you have to do a second surgery. And even though it's an outpatient surgery, that in itself has a significant cost component. So when you add the two, not a lot of savings. The other part of it is, the truth is, this should only be done with implantable because otherwise it's not a cosmetic procedure. But socioeconomics, listen, if you had the availability we have of implantable nails, it would probably mostly be done that way. The centers that are doing it still with X-Fix, both in your country, in Turkey, some of the other countries, are mostly doing that to reduce costs or because of lack of availability. I mean, NuVasive doesn't sell this in every country. And currently, they're really the only one on the market. There'll be a couple other nails coming out soon, but you have also the Fitbone, which is also just as expensive. So not practical. But from a point of view of a cosmetic procedure, it's no argument. This is it becomes a cosmetic procedure when it's invisible. And the nail is as close to invisible as possible. In fact, you know, in 2018, they came out with the stride nail, which was a full weight bearing nail. And so then you did the surgery, and within less than a week, a patient was walking without walking aids, without crutches, without a walker. So patient could be walking around and nobody would know. The incisions are minimally invasive. They're tiny incisions. If you do this properly, the nail lengthening requires, actually the biggest incision for the femur is the IT band release. All the rest look like mosquito bites. Okay. And, you know, so it is fairly invisible operation. Stride nail went off the market in 2021 due to corrosion, because it was a stainless steel implant and there were some corrosion issues. December or January this year, we're waiting for a new nail that I've helped them develop. I developed the stride nail originally, and I've helped them develop this new nail, which is called the Max nail. And the Max nail is made of titanium, so it won't have corrosion issues. We hope it won't have any other issues, but you know, the stride nail had no other issues. It was only the corrosion. Did incredibly well as a limb lengthening nail, incredibly well. And it proved the point that patients could pretty much walk around almost normally with very little limp during that. Probably, if you think about it, if you're not on crutches, you never get weak. Your anti-gravity muscles, which are your glutei, your quadriceps, and your gastrocolius, those are your anti-gravity muscles. They never get weak if you're not on crutches all the time. If you're on crutches all the time, of course, they will atrophy a bit. These patients are really not getting that weak, so they don't get much limp during the lengthening. And so they lead fairly normal lives during the lengthening. That's when it's beginning to be on par with our concept of a cosmetic procedure. And it's the concept. Think about it. Can you imagine that if someone wanted to have a breast augmentation, they would be put in a wheelchair or on crutches or a walker for 3 months? Unimaginable. What woman would go and have that done just to have a breast augmentation? Okay. And can you imagine, you know, if they were going to have to be 12 weeks at some center away from home? So we're never going to be like any other cosmetic procedure, because the risks of this procedure are much higher, and the interruption of normal life is much higher than almost any other cosmetic procedure. You know, by the way, we're also doing this as an inpatient procedure. Most other cosmetic procedures are done as an outpatient. I don't know if this is a thing in India, but in the US, everything's going to ambulatory surgery centers away from inpatient hospitals. What prevents us from doing that right now is not so much the pain factor, but the danger of fat emboli. I mean, as Michael correctly pointed out, although the incidence is small, there's about a 4% incidence of fat embolism, symptomatic fat embolism. What is symptomatic fat embolism? A drop of pulse oximeter measurement that cannot be explained by any other cause. Not pneumonia, not a pulmonary embolus from a DVT or something. And it occurs sometimes as early as the recovery room. Okay. Talk about knowing how to deal with this. If you don't know how to deal with this, especially with nail lengthening, then you're going to lose some patients. Okay. And, you know, that's why Michael mentioned the availability of an ICU or even ECMO. I haven't had in my career one patient end up on ECMO. Okay. He survived. I've not lost a patient yet. but I've had 2 patients end up in the ICU. We have a 4% incidence of fat emboli. We've dropped it recently. It'll be interesting to study it because we have a paper on the original incidence. We've measured, we've changed our protocol. So you got to use reamers that are especially sharp and especially deep. So they actually don't generate as much fat embolism. You need to ream slowly. You need to create venting in the femur, easy to do with multiple drill holes at the planned level of osteotomy. In the tibia, if you do that, you'll get a compartment syndrome. So we don't do that. Okay. And so the giving albumin ahead of time reduces fat emboli. Being on alert for it in surgery, where you look for increased ventilation pressure, where you look for drop in pulse ox and drop in blood pressure. Those are your 3 indicators. And our anesthesiologists are watching this the whole time. And if they see anything, they notify us. So we slow down, we stop maybe for a while, consider not doing the second side and coming back another date. You know, all these things are really important. If you've just taken a course and how to stick a nail in, you're not going to know any of this. Okay. This is really important. This is part of what I was saying before, knowing how to prevent as well as treat the complications. And how do you treat it afterwards? By the way, I mean, we've identified that the highest risk group are vapors. Both patients who ended up in the ICU, the only commonality of them, they were both young, by the way, but they were vapors. And we think vaping causes predisposing lung damage that's even worse than smoking. Okay, so it's a new modern disease that we're facing. So yeah, that's kind of my comments.
So Dr. Pelly, interestingly, I used to, upon the recommendation of your previous partner, I used to not do vent holes in the tibias as well. And then what I realized is that you can only drill the anterior cortex of the tibia, and maybe a very distal hole medially during the whole reaming part to get essentially that vent, and right before the osteotomy, finish the posterior and lateral cortices.
So I've done that, only drilling the anterior cortex. Haven't been impressed by the amount of vents, but it's created another problem, is that you get, and you have to, you get some of this bone sitting under the skin, and you got to make sure you correct it out, because otherwise I've ended up with a little HO there. I don't think you get as much fat embolism from doing the tibias. So don't know why, but you don't seem to. So I've stopped doing the anterior drill hole. I did that for a little while. And the one thing we don't do, I have done, but we don't do, is I don't do 4 nails at once. My limit is 2. I have done 2 patients where we did 4 nails at once. And one of them, nothing happened at all. And one of them did get fat emboli. So not severe, but, you know, so you know what, my coronary arteries can't take it. I do 2 nails. And interestingly, in the past year, because we watch our numbers, our incidence of fat emboli have dropped to about 1% when it was consistently 4% for many years. And I don't know why that is.
Okay, Dr. Pelly, I have a question. Like in India, we don't have precise nails yet. So will you be recommending doing limb lengthening on hexapods or LRS or the classical Elizaro? As you said that it's a cosmetic thing, so it should be only done by the implantable nails. So what's your recommendation?
I can't say that. I didn't mean to say that. I said ideally. Look, before we had fully implantable nails, Okay. So before the year 2000, well, I started in the 1990s with the Albizia nail. We had a few of them, but most of the 90s, we did LON. In fact, originally, before I developed LON, because I did my first LON in 1990, okay, and my first cosmetic case was 1988. I did purely fixators, and I only did tibias. And then we went to LON. And LON, I don't, is Mangal still on? I don't agree with you, Mangal, about femur LON. I've done so many femur LON, and you can get the nail. If you look at my original article in JBJS 1997, shows you how to put the fixator on and avoid touching the nail, because you should not have a communication to avoid infection. And I think you can do it very safely, and you end up with enough nail in the distal part of the femur to stabilize it. So I don't think that's a problem. LON for the femur is a good technique. And in fact, there's many advantages of lengthening the femur versus lengthening the tibia. You lengthening a tibia, you're more limited. You can lengthen up to about 5 centimeters max. If you start going beyond that, you really start getting into equinus contractures, equinus, equinovarus. So we rarely lengthen the tibia more than 5 centimeters. With the circular fixator, you can kind of do that because you can hold the foot, but I don't like to do that. I like to I like to exercise the foot, and I don't like to immobilize it because I think you do get some stiffness. So I think you can do it with circular fixators below the knee, monolateral fixators above the knee, both over nails. Why over nails? To reduce the X-fix time. And you significantly reduce the X-fix time. You significantly reduce any, axial deviation. Rob Rosbrook prefers lengthening and then nailing, which is a variation on the theme, where you're using a circular fixator on the tibia, lengthening, placing your pins out of the path of the planned nailing, and then coming in and nailing. I personally prefer lengthening over nails. Dealer's choice on that. But either of those achieves the exact same thing, which is the ability to remove the external fixator at the end of the distraction phase. And so it removes that problem of waiting forever for the consolidation phase, and removes the consideration of fracture or bending or so on. And it reduces axial deviation as well. So I think that under your circumstances, if you cannot get fully implantable nails, it is completely reasonable to do it with LON. Look, it's reasonable to do it with X-fix. It's just going to be much harder on the patient.
Okay, sir. Thank you. And Siddharth, there are some questions in the chat. So will you like to discuss these questions with the panel?
Yes, sir. I think because we have very experienced people sitting on the panel, so it's good. So some of the answers have already been given, but there is this recent question by Dr. Arvind, like, what are the chances of infection in lengthening over nail, and how do you manage it? The question is addressed to Dr. Mangal Parihar, sir, if he's here.
I think
No, I
he's
think it was
busy.
glitch.
I think he's
but,
busy in the conference.
He must be busy, but the same question to Dr. Paley and Dr. ASSAYAG, like, how do you manage infection, if at all, if you do have infection with lengthening over nail, how do you manage it?
So I've published on both subjects, the LON technique, and we reported, I forget, I think maybe a 4% incidence of infection. And we reported how to prevent that, like including locking from the medial side instead of the lateral side to stay away from the fixator and its pins. So there are ways to reduce that risk. But if you happen to get an intramedullary infection, it is actually not a hard infection to treat. It is localized to the medullary canal. And what you do is so if it develops while you're still lengthening, then what you should do is, if there's an abscess, you got to drain it. And if you can continue lengthening, but you need to suppress the infection. You suppress the infection with IV antibiotics. By the way, it's the same thing if you have it with an implantable nail. Drain it if there is something to drain. If there's nothing to drain, just suppress it. And then wait until you can take the nail out. So you stay on suppressive antibiotics basically until the bone is consolidated or until you can take the nail out. So what allows you to take the nail out? Either full consolidation of the bone or being willing to exchange nail with an antibiotic-coated nail. Now, there are two different types of solutions for both those situations. If the bone is fully consolidated, but you have an infected medullary canal, you take out the implant, you ream the bone, you wash out the antibiotic impregnated cement, either absorbable or non-absorbable, into that space with minimal or maximal metal. Let me explain. If the bone is healed, doesn't need much protection, we published a paper in 2001 using a beaded guide rod and regular cement impregnated with antibiotics. Okay. Since then, it's easier and you don't have to take out because that's still an implant. And cement eventually is a porous implant that can actually harbor bacteria after it elutes it. So to avoid removing that, we now use absorbable cement. What's absorbable cement? Absorbable cement is calcium sulfate, which is basically plaster of Paris. Now, don't just go take your plaster of Paris and do this. It is a sterile plaster of Paris. And it is, in our country, it comes under the label of a product called Stimulan, but I think there are many of these calcium sulfate products out there. It basically absorbs in 6 to 12 weeks, okay? And you can inject it as a liquid, and I used one of these long tubes that you inject down the canal like a cement, with a cement gun. I inject it from the bottom up, and then you would put a rush rod. We have a similar device called the slim rod that we put inside just to protect the bone. That's in a healed bone. In a bone that, let's say, you still have to wait for the regenerate to heal, but you don't want to wait and be on IV antibiotics for so many more months, then we would if we have no fixator on, because it's an implantable nail, we would put a temporary X-fix anteriorly, okay? Just need 2 pins, one proximal, one distal, and a bar. Take out the existing nail, ream out the canal, do exactly what I just said, except now we would put a regular lock nail with Stimulan. We used to prepare PMMA impregnated cement, coat the nail inside of a silicone tube. You can buy silicone tubing at the hardware store, sterilize it. We used to use chest tubes, but they melt when this PMMA heats up. So it's better to use silicone tubing of the diameter you want, put your lock diam nail in that, let it harden. But that takes time to do. I don't even bother with that. I just inject Stimulan and shove my nail down. Stimulan's liquid, and I shove my nail down. That saves me about half an hour, okay, of all the preparation. And it is easy, it's quick, and it's effective. And that's what we do if we want to, so we'll exchange nail that, lock the nail, take the fixator off. Okay, that's if we have a regenerate that's going to collapse. Okay, and there's one more category that you should ask about, and I'll just volunteer it. And that is, what if you have a patient who's had a previous external fixator on, and you're going to put a nail in? So there is a certain incidence of provoking an intermedullary infection. And what we found is it's 17%. It's an unacceptable number, 17%. So then what we start, so the reason that this happens is you have all these latent forms inside the bone since the X-fix went on. When you go in with your reamer, you devascularize the canal, and you create a very good environment where your own blood cells can't come and attack and prevent an infection. So the bacteria might get reawakened and flourish there. So what we do now, if they've had a previous X-fix, but not really any history of osteomyelitis or anything, we will give them 2 weeks of antibiotics after surgery. So you get oral antibiotics for 2 weeks after discharge from hospital. In hospital, they'll get IV vancomycin for 3 days, and then they get discharged on oral, okay, like clindamycin or Bactrim or something like that. There's something that covers, covers MRSA. There's another subgroup, and that, by the way, since we did that, we've reduced our recurrent infection down to 1%. It's from 17% down to 1%. There's another group where you have a history not just of an X-fix, but they had a bone infection at some point. It was worse. They had big holes, that you're worried. In those patients, when I put a nail in, ream the canal, I inject stimulant from day 1, and we put the lengthening nail in, or the lengthening over nail in, whichever one it is, because that's a high-risk patient. The stimulant does not seem to get in the way of making regenerate. Okay, it's osteoconductive, so probably not a problem for the lengthening. I think in Baltimore you use similar protocols, don't you, Michael?
That's correct. That's correct. Actually, I still use the PMMA impregnated coated nails, except when doing a precise nail with a previous external fixator, in which case we found that it doesn't hinder the mechanism by just injecting the calcium sulfate, inserting the nail, and the nail just lengthens properly and as intended. So that's really my protocol.
Yeah, we've, well, first of all, you can't put PMMA on the precise nail.
Exactly.
Not going to work very well. But and that's prophylactic. That's not therapeutic, because if you're doing therapeutic, you're on a solid nail.
Correct.
We've just stopped making these. Look, my publication was the first one out there on putting a PMMA nail inside the bone. First with a thin implant. Janet Conway then, published on that with a lock nail, and that works very well. Takes more time. You have to prepare these. It's a little more complicated. The stimulant is so easy and quick. You mix this stuff and you inject it right away, and you stick your nail in. So you don't have to bother with the molding of, molding of the cement and cutting off the silicone tube or chest tube or whatever you're using. You don't have to worry about any of that. And you don't have to worry about removing it. And let me tell you, sometimes they're not so easy to remove. Okay, or some of the cement stays behind after you pull it out. It breaks off, it flakes off. So With the stimulant, we don't have any of that issue anymore, and it's just as effective. And it carries, remember, it's only important for 6 weeks. You don't need this for more than 6 weeks. So, and the stimulant lasts for 6 weeks. It's done eluting after 6 weeks. In fact, the antibiotics are more readily elutable from calcium sulfate than they are from PMMA. So another reason to consider, and it's osteoconductive. So if there's any bone healing going on, it probably can, it doesn't hurt it. If anything, it helps it.
One of the caveat that I would add is that I've seen catastrophes in people who didn't have all their ducks in a row when the stimulant was injected, whereas the stimulant hardened before the nail was in, which yielded obviously the catastrophe that you can think of with bone fractures, false trajectory, and so forth. So just know for the participants that if you are going to undertake this treatment, make sure that the nail is nice and ready to be inserted before injecting the calcium sulfate.
Yeah, and make sure you inject it like immediately when it's at the second it's mixed and liquid enough. Inject it from bottom to top. Don't worry about coming out the holes. You can clean those out after, and then put your nail in, whatever type of nail in. Don't worry about the locking. Locking, you can drill through the stuff, but
Right.
even the PMMA, you can drill through that stuff. But just get the nail down that canal.
So, Dr. Paley, a quick follow-up question on Stimulan. So we do get Stimulan in India, and I'm pretty sure all of my colleagues here have used it. What's the typical amount of the amount that you use? Because we get it as 5 cc and 10 cc. So how much Stimulan would you typically put in the tibia?
So not just tibia, femur, or whatever. You know, I'm not sure I know the answer. Maybe Michael does, but you know, we mix it, and then if you're putting a nail on top of that, okay. So it depends. Sometimes it's just the stimulant going in, maybe with a rush rod. If you're putting a nail on top of it, the nail takes up a lot of volume, and but I like to fill the canal and then have it all squirt out. That's my approach. Now, you could do a simple calculation. 30 centimeter medullary canal with, let's say, to make the math easy, a 10 millimeter diameter was reamed, okay? So 30 times 10 is 300 what is that? 30 centimeter, yeah, 300 cc's. Okay, so you need 5 cc's is not enough. Okay, so you need a lot of this stuff. This stuff, come on, it's got to be cheap even in India. This is plaster of Paris. Okay, if they're charging you a lot, then go make it yourself. It's not hard to make and sterilize it.
I have one question with the panel. Like in India, majority of the cases we do lengthening in cases of bone defects, especially in cases of infected non-union, where we did a proper debridement and we wait for the wound to heal, and then we do an osteotomy to lengthen for the defect. Like there are some people who say that even if the wound is red and there's not much infection, you can go for the osteotomy, because osteotomy will help in minimizing the infection. And some says that you should wait for the wound to completely to heal, how much time it may take. So what's your take? Like, we should wait for the wound completely to heal to go for an osteotomy, or we can go a little early also when there is no visible sign of infection in the wound?
Yeah, I don't really care if there's a wound or not wound. I mean, a percutaneous osteotomy, if you debrided the bone right there, so it's a wide open, big hole in the bone that was previously infected, I have no reservations about, you know, these are usually fixator cases, about doing a percutaneous corticotomy of the tibia, let's say, in the proximal tibia, and having a distal big open wound that I just debrided. What I do is 2 setups. I'll do the dirty part of the procedure first, and not even allow my, you know, whatever hardware I'm going to put in to be opened yet. And then we'll re-prep, re-drape, and new equipment, not use the same forceps and scissors and drills and everything. So it's a clean procedure as far as I'm concerned at that point.
I mean, we routinely will perform soft tissue transport along with bone transport after doing a corticotomy for soft tissue defects that accompany bone defects. So as Dr. Pillay just mentioned, this is not part of the equation. The equation is what is the treatment necessary to solve this problem? And that's it.
Siddharth, is there any other question?
So yes, sir. In fact, I can see one more question from Dr. Sunil. If you are doing a femur lengthening with the lengthening over nail procedure, do you still need an iliotibial band release in all of your cases?
Got nothing to do with the lengthening over nail.
Yeah, exactly.
Even in fact, with lengthening over nail, you definitely need it, but you need it in all. If you're doing in all your stature lengthenings, I do a distal IT band release in 100% of them. Okay. In a certain percentage, I also, not instead of, I also do a proximal. So the question is what's my indication for the proximal? The proximal ones are being done. If I cannot adduct the leg, cross the leg over the other leg, you know, when you do I do my nailing supine and I cross one leg over the other. Okay. And I get my starting point in the piriformis fossa. In order to do that, I need to cross the leg. Some people's proximal fascia lata is so tight, you can't do that. That isn't it. First of all, it makes it difficult to do the surgery. Secondly, it's an indication they're going to end up with that kind of wide base gait. They're going to be stuck there, even with the distal lengthening. So I start by releasing distally. And that is a transection. It's a 3 centimeter incision on the lateral side of the leg at the level of the superior pole of the patella. Okay. You go down, you actually go on the back of where the intermuscular septum is. And I go in, I cut the iliotibial band in the front. I actually cut the intermuscular septum. Just be careful, you got the lateral geniculate artery that bleeds if you get it, you know, it's not nice. And then I actually go back to the biceps muscle at that level, and I do a fractional lengthening, just cut the aponeurosis there. You're there, it's free. And so after that, I test it. And if it's still tight to adduction, I'll make, at the level of the greater trochanter, I make a 3 centimeter incision. And then you cut with your knife. It's basically a blind cut. You cut on the iliotibial band till you get to the GT, okay, greater trochanter. And then you take a blunt scissors and you put one part on one side of the fascia lata, one on the other, and you run it up and you run it down. It is so thick, especially when you run it posteriorly, you hear it break. And then you can adduct the leg and they don't get a problem. If, by the way, they come in like Michael showed that, you know, after rehab a year later, they're still walking like that, that's the solution. That little operation I just told you makes it go away, has very little downside. Neither of these create a muscle hernia, by the way. If you cut the IT band anywhere in the middle between those two incisions, you'll get a muscle hernia. But there's no muscle at those two locations. So.
Thank you. So, Dr. Rajat, I think we are almost at the end of this masterclass. It's 3 minutes.
I think, Siddharth, you had a case discussion. Will you like to present that?
So I think we are run out of time, sir.
Okay.
We have the masterclass from 8 to 10, but if there is any question from any of the panelists.
One thing I will, just one thing, Siddharth, I would like to request Dr. Pillay, like when we have young surgeons coming out, most of them actually ask for, since there are not much books on techniques of basic techniques of Elizarov or deformity correction. So they ask for all the articles. And since Dr. Pelli has written extensively from A to Z, I think on every point which is there, every topic is there. So is there any way where we can get all your main articles and give it to the youngsters, because they don't have the money at still that stage to buy every article. So
Yeah,
it will be a great gift to all these surgeons.
I can email you. We have a Google Drive with all my articles up on the Google Drive. They're welcome to download them as much as they want. I'll just send me an email, remind me you want the Google Drive, and I'll make that accessible.
Okay, that will be great. I think that will be the best gift for all the young surgeons out there, sir. Thank you very much for that.
You should ask them.
In future,
they have a lot of articles from Baltimore. So, you know, I don't know if you guys do a similar thing, Michael, but, you know, Dr. Herzenberg and Dr. Standard and, you know, many of my articles were from Baltimore, and, you know, and then Dr. Conway and Dr. ASSAYAG now, and Dr. Bibbo and now Dr. McClure. I don't know, have I left anyone out at your place?
No, I think you got it all.
You know, so they're also a very experienced group who have a lot of and you know, they've published a lot. So I'm sure if Michael has some other way to make them easily available, that would be useful to your young surgeons too.
thank
We
you,
have
sir.
them
That
all
will be-
gathered on Zotero, but I'll see Rajat if we can put them in a Google Drive or OneDrive and send them to your way.
Okay, thank you, Michael. I think it will be a great gift to all the young surgeons out there. And I take this platform to invite Sir Dr. Pele, sir, and Michael. We have the Asami Con in 2024 in April in our much loving Goa. I think, sir, you must have been there like 5-6 times minimum.
In India
Because
or
from
in Goa?
my yeah,
I've
because from my
been to India 20 times, and I've been to Goa, you know, several. You don't know this, but my last trip to India, I contracted COVID.
yeah, in Delhi, sir. Yeah.
Yeah, and I may have been your first case of COVID. Well, I guess not the first, because I got it from someone else, but maybe the first documented case. I ended up hospitalized with pneumonia in Abu Dhabi after the conference. So
Okay.
that was my last in-person trip to India. So, but I love India, and I've been there 20 times, and I hope to be there more times. So.
Okay. So one thing I will say, I'm always fascinated by your facts. Like whatever we ask you, you exactly know the numbers. I have been done this much of times. I've been come here this much of time. You are so clear on every data on every topic. And that's fascinating also. And one thing more,
That's
I've
called
always
getting
heard.
older. I said that's called getting older, and that's why that, you know, that I never understood that you know, that expression sage advice. You know, I think it's a nice way to say you're old. So I've been doing this 36 or 37 years, and I hope that you know, no one gets to do this forever, but I hope I get to do it for a little bit longer and share some of this wisdom with this next generations.
Thank you, sir. Thank you so much. And I'm thankful from on behalf of Asami India to Dr. Michael and Dr. Pele and Dr. Mangal and Siddharth to make this webinar a wonderful one. Dr. Mangal is here. So any closing comment, Dr. Mangal, sir, on the topic?
I think Michael and Dr. Bailey covered up or reinforced many of the messages, I think, which I wanted to give. I think that's important. That's it.
Okay. Now, the last and not the least, we have Dr. Chaudhary also in the panel. I think this is a wonderful panel today. So maybe some few inputs from Dr. Chaudhary also about the cosmetic limb lengthening. to have a complete discussion.
Well, very kind of you to invite me. I think very little remains to be said after hearing Drawer, and I'm not tremendously fond of this. I do very occasional surgery. I perform very few of these with the anti-hexaplastic status with the TSF, not having access to the precise. I carefully select my patients for the lesser amount of headache they're going to give me. And all the things that Drawer and Michael have said are germane, and Mangal has said are very germane. I'm very circumspect. I'm very careful about deciding them, but really I have nothing more to add. Everything has been said before. And the cautionary note to everyone, to the younger ones who are venturing into this, should remain uppermost in their minds. Thank you very much for this lovely webinar. Thank you, Drawer.
Milan, lovely to see you. I didn't realize you were there.
Great. Lurking as usual.
Thank you, sir. Thanks again for coming. And sir, I will be sending an email to Dr. Pele and Dr. Michael for the articles, and I think it will be a great help to our young surgeons. Thank you, sir. Thank you once again from Asami, India.
Bye.
Thank you.
Thank you, everyone. Bye-bye.
Thank you. A wonderful seminar.